In today's episode, we're going to be talking about breast reconstruction, the options, and what it feels to be whole again. Hello, I'm Amy Dowden. I'm one of the professional dancers on Strictly Come Dancing. 2 years ago, I was unfortunately diagnosed with breast cancer. And after a mastectomy, chemotherapy, I'm very proud now to be on the other side and super grateful to be there. But now I'm on a mission to do all I possibly can to raise awareness, break the stigma, and to learn as much as I possibly can about this awful disease.
Hi, I'm Naren, one of the breast surgeons in Birmingham. I've been looking after individuals who've been touched by breast cancer for almost 2 decades, and it's a real privilege to be part of your journey and these collaborative efforts to try and improve awareness about breast cancer.
Welcome to Breast Cancer Uncovered.
Our first guest is Miss Georgette Oni, a plastic surgeon who specialises in breast reconstruction.
Right, I want to know, what exactly is an oncoplastic surgeon, if I've got that right?
You have got that right. That's a very good question. So an oncoplastic surgeon is essentially a breast surgeon that uses plastic surgery techniques to remove your cancer and to reshape your breast. So there are varying degrees of what oncoplastic surgery may involve. So it might be something very simple by way of where a scar is placed to be able to access the cancer, to remove the cancer, or it might go all the way up to what type of reconstruction you have.
So what is the difference between both of you as surgeons?
If we look at our training, so Naren would have trained through a general surgery pathway. So he would have done things like removing bits of bowel and things like that. Whereas I trained through a plastic surgery pathway, whereby if a bit of bowel was removed and there was a big hole, I would reconstruct that defect. So we've gone down different routes, but arrived at the same point, as it were.
And I'm guessing then you work together during surgery.
Go for it, Georgette. Yes.
Yes.
Georgette,
yes. So breast surgery is becoming a very sort of team, it's very team oriented, as I'm sure you've been hearing. And there are occasions where you only need a breast surgeon, for instance, to do your surgery. And there are times where you only need a plastic surgeon to do your surgery. And there are times where you need a combination of both.
And what are the different types of reconstruction surgery?
So there are lots of different types of reconstruction surgery, and it starts right from the beginning in terms of there are partial reconstruction techniques and there are full reconstruction techniques. So essentially, you can have a lumpectomy and that you have a defect that's left behind that needs to be reconstructed. So you're not reconstructing the whole breast, you're reconstructing part of the breast to restore the shape. Or you can have a mastectomy, that's when we take away all of the breast tissue and within it the cancer. Or if you're having it for risk reduction, you're taking away all the breast tissue to reduce your risk of developing a cancer. And then we can reconstruct the whole breast. And there are different ways that you can do that. And there are different times at which you can do that. So you can have it done immediately, or you can have it in what we call a delayed fashion. So that might be weeks, months, or even years down the line after you've had your primary surgery to take away the cancer or the risk reduction surgery. In terms of the reconstruction, there are different types in that you can either use parts of the body, essentially, so local, so things that are nearby the cancer site. So that might be within the breast, adjacent to the breast, or you can use distant sites. So one of my favourite operations is taking that roll of tummy that you have and building a breast with that. That's called a DX flap. Or a lot of women actually, in fact, most women around the world, their form of reconstruction, if they were to have a mastectomy, is an implant-based reconstruction.
Georgette, I guess the question is, what would make you recommend one reconstruction over another, or is it a sort of common ground with your discussion with the patient in front of you?
So it's always a discussion with the patient. It's important to understand what the goals and ideals of the patient are. I think I always tell patients it's a given. We are going to remove the cancer. So this is really about what and how you would like to live after that cancer is gone or after that risk reduction surgery has been performed. So you will have some women who will not have reconstruction at all. They're very happy to go flat. But a lot of women do want reconstruction, whether that's partial or total. And it's a discussion about what's available to them, because not all options will be available to women. It's a question of logistics. It's a question question of timing, and it's also a question of what other treatments they may or may not need afterwards.
Okay, and in terms of the difficult scenario that you and I face when we're talking to someone, and it's about managing expectations, any sort of tips or tricks you can tell us that you've developed when talking about someone about breast reconstruction? How do we best manage expectations?
Yeah. It's a really difficult time for women. It's really it's a lot of information that you're giving people in a very short space of time, and you're asking them to make a decision when their life has essentially been turned upside down. I write a detailed letter to the patient so they've got something they can read over later on. Breast care nurses are fundamental. They're absolutely critical in terms of bridging gaps in knowledge or a reconstruction. I think the important thing is that there's like a team all around that patient helping to support them through this difficult time.
And in your experience, do you think there are things when you see a patient in front of you, are there sort of patient factors that will make, whether it's cultural, whether it's ethnicity, that will make an individual choose or not to choose a reconstruction?
So absolutely. Like I said, there are some patients who come in straight away and they know what they want. No, they don't want a reconstruction. Yes, they do want a reconstruction. The literature shows that if you're from an ethnic minority background, you're less likely to have reconstruction. Now, whether that's cultural, whether that's fear of more surgery, it is multifactorial. Is it religion? It's multifactorial. I think what's important is listening to what the patient wants and then explaining whether or not that's practical, feasible, the timescale over which that can be delivered. Because sometimes you can give them what they want, but just not right now. We often see that younger women, for instance, will opt for implant-based reconstruction because they want surgery that's going to be quicker to recover from, so they can move on with the other things they've got in their life, like working and children, etc. So, there's lots of things that play into whether or not a woman will have a reconstruction.
I couldn't have imagined that, because, yeah, you can't really close the chapter on your cancer diagnosis then.
Oh, yeah, for sure. I mean, we are getting very good at treating breast cancer, right? So what we want is for women to have, they have this horrible diagnosis, they get their treatment, and then they get on with life afterwards. And our role is to do what we can to help facilitate that for them. And even with reconstruction, I do tell women that, your cancer treatments may well be done, but you're going to be coming back to see me over the next year or next couple of years so that we can get your reconstruction finalised. And that is also disruptive, but a very necessary part of being able to move on and heal from their diagnosis.
When I was told I needed a mastectomy, I straight away said, can I have both off? What I didn't want is to be getting back on with my life and it to come back in the other breast and to be in this situation all over again. I just wanted to be done with it there and then. I was advised, no, at the time it wasn't right because they wanted to deal with the cancer and the risk of infections, everything like that. I have Crohn's disease, so I'm more risk of infections and things like that. And I was just told to just focus on the cancer and, we would deal with the other breast later down the line. But is that the generic answer within the NHS?
I think that is a great question and a really difficult one to answer. So if we unpick that, when an individual is diagnosed with breast cancer and their world has fallen apart, we've shown that actually their ability to predict what their risk is exaggerated. So they will feel what their risk is beyond what it currently is. So that's the first thing. It's also about understanding, is there a objective risk of developing breast cancer on the opposite side? The common myth is that one breast cancer from one side travels to the other side. That doesn't happen often at all.
A lot of women, they get diagnosed breast cancer and it completely blindsides them. I've had women who want to have the other side removed, and we've talked through risk, we've talked through survival, we've talked through what it will mean for things like relationships. So, we know that if you have a reconstructed breast, it's not going to feel the same as a native breast. And so it's even just exploring things about how they might feel, to have the other side removed, because it may at that time feel like that's the thing that they want, but actually when you talk through it and you explain that other things that will be there to support them in early detection, so things like you will be under more increased surveillance, you may be on medication that is reducing your risk in any case for a period of years afterwards, how to properly self-exam, all of these things may help to reduce the anxiety around that and time.
So maybe, Amy, we've done what all healthcare professionals do, is answer a question by not answering it.
No, probably at the time I was very emotional and just probably thinking, I was worried about the future and it coming back, I wasn't looking at all my options, if that makes sense.
Yeah, and it's a very difficult discussion, I think. We to and fro in terms of our own debates, and there's no right or wrong. I know that across the pond in the States, there is more of a trend for newly diagnosed breast cancer patients to have a double mastectomy, as it's called. There are other drivers for that, which are probably different to our own healthcare system, but it's definitely a trend that is being observed. You're right, yeah.
I'm really happy with my plastic surgery and my implant. Actually, my husband was like, gosh, he said, they're twins now. He said they used to be cousins. But what would you say is the research and the development for plastic surgery?
So there's lots of things that are coming on the horizon. Obviously, implants themselves have been through lots of iterations and versions, and some of the newer ones are very sort of natural feeling. So there's lots of research around, implant and, implant and the way that it feels naturally within the woman. There's lots of developments around fat and about fat reconstruction and whether you can use fat that's harvested through liposuction from other areas to be able to build breasts in a way that an implant might. And so there's lots of sort of bioengineering things that are happening at a sort of research level. In terms of the surgery itself, so I mentioned earlier that you can use different areas of the body to reconstruct the breast. And traditionally, we used to use the big muscle at the back, which is called the LD flap. I think very rarely now that we're using that. We developed microsurgical techniques. And so that allowed us to take, like I mentioned, the tummy roll to build a breast. But you can now take that fat from thighs, you can take that from buttocks, you can take the love handles, the muffin tops, you can use that. So those microsurgical techniques have advanced in terms of which parts of the body, and also the way in which those techniques are performed. So they're less invasive, less intrusive. We now, a lot of the conferences now, they're talking about using robots to be able to perform mastectomies, raise flaps for the reconstruction, or even your implant-based reconstruction. So robotics is going to be a big thing, and then the use of AI. So, when we're doing things like microsurgical reconstructions, we use a roadmap, which we've got from imaging and things. You now have got like Google Glasses where you can like overlay like the images of the vessels and things when you're operating. You can use it for teaching. You can use it for just improving your kind of surgical time and efficiency. So there's lots of things happening. Whether we're going to get them in the NHS anytime soon, probably not. These are all very expensive. They're very experimental. But I think if we were sitting here in like 20 years' time, I expect I will be doing my surgery from my bedroom through a robot, hopefully.
Wow. Thank you so much for, giving up your time today to speaking with us and informing us and certainly educating myself. So thank you.
Absolute pleasure.
Can we now turn to Louise? Louise, you have worked with the charity Breast Cancer Now for the last 6 years. How important do you think it is to really give the patients the correct knowledge?
I think it's vitally important. I think when somebody's faced with a mastectomy, having to have a mastectomy, talking through the options that they've got is so important, that they have the right information for all the suitable options for breast reconstruction. It's such a personal and a complex decision, but a time that's sort of highly emotional, and also with time constraints, to be given that information to make in usually a fairly short space of time with so much information to process can be difficult.
I remember personally saying, oh, I don't want reconstruction. And it was my surgeon who said, no, you will regret it. You really need to think about this. And I think I just wanted something that was going to be quick and easy. That's what I was thinking. And I'm so glad I went for reconstruction, and I'm so happy about it.
There's certainly the sort of three main options. Is one, for no reconstruction, and some women choose that, and it's a personal decision as to why they may want that to remain flat with or without breast prosthesis. But then there's obviously the option of using your own tissue if that's suitable for you, or an implant-based reconstruction. So, and I think even as healthcare professionals, there's so many more options. When I first started out as a breast care nurse, that then conveying that to somebody who's not within the field of surgery or breast cancer can be a real minefield. But I think it is about managing those expectations as well. For people adjusting to breast reconstruction afterwards, it's about having all of that information to prepare them for what to expect after the operation.
Yeah, I think for me, I'm not very busty, but I can just remember the surgeon saying, have a really good think about it. And then I just thought, with all the dance costumes that I wear, it's a very personal opinion.
Yeah.
And can you choose later down the line to have reconstruction?
Yeah, exactly. So I guess when I'm faced with that conversation, I try to break it down into two very simple questions. The first is, does that individual want a reconstruction now? We call that an immediate reconstruction. Or does someone want a reconstruction later? And that's called a delayed reconstruction. So that's the first question. When would someone want a reconstruction if they did? The second question I ask people to consider is, if we're going to be doing a reconstruction, how would you want that volume to be got? Because if that volume is using their own tissue, we call that an autologous reconstruction. Then the pathway goes down a slightly different road. If they were not suitable, not keen for that, then the option would be to use some form of implantable device.
I didn't have the option to save my nipple, but there are options as well, aren't there, to even save the nipple?
Yes, of course. That's a great question. So for someone being offered a mastectomy, the questions I imagine they would want to ask is it suitable for a nipple-sparing mastectomy? Some women will have large, heavy breasts where the nipple has dropped with time. And for those individuals, we may offer them a type of mastectomy where we tighten the skin, and that may be called a skin-reducing mastectomy. There's variations, and if someone ends up not having their nipple preserved, there are definitely options down the line.
Yeah.
Yeah. What concerns have you found from your patients over the year?
One of the questions is, and I think that's what Naren was saying, is some people will come with preconceived ideas. They'll sort of say, well, I want to use my own tissue. For whatever reason, I don't want an implant, but they may not be suitable for that implant. I think the other thing is, it's safe. Is it going to delay my cancer treatment if I have a reconstruction? I think it's, how am I going to look afterwards? And scars, and some people with using their own tissue, it's about having additional scars. So even dealing with the scars from having an implant-based reconstruction, they'll sort of say, I know I've got to have that because I've got to have a mastectomy, that's the breast cancer, but then having to deal with maybe additional scars on your tummy, in your inner thighs, on sort of on your back for some reconstruction options, that might be too much. Or it might be about the recovery. It may just be their personal situation. So maybe single parent, they've got children, and that may also influence the decision around what they choose with regards to their reconstruction. So having your own tissue reconstruction is a bigger operation, a bigger, longer recovery usually. And if somebody's got young children with limited support, that may be an option that they just can't, although they might want it, they won't consider it because that's just not a doable thing for them practically.
One question we get asked regularly is a reconstruction safe from the perspective of the breast cancer? And I think it's fair to say it is, and that's why we offer it. It's not going to impact on the actual cancer therapy, cancer treatment. So when someone goes in for a mastectomy, some bits will be predictable what the results show. A lot is unpredictable, like is the lymph node involved? How big is the lump? Is it bigger than we thought or not? Because all these factors will then impact on other additional treatments, for example, radiotherapy.
And there's got to be a certain margin, hasn't there?
Correct, yeah. So the edges, even at mastectomy, the team will examine under the microscope how complete that removal has been. So, and that will have an impact on the reconstruction offered and also the success in the long term of that reconstruction.
Yeah. Do you feel that women who have gone for reconstruction have mentally been stronger afterwards, or not really much of a difference?
I think it's such an individual response. I think, and we've alluded to it before, I think it is the preparation, the information and managing those expectations up front is so important to allow people to adjust afterwards. I think, again, at breast cancer now and in my experience as a nurse in NHS practice, for those that maybe haven't been prepared and they've come back, and one of the things that often comes back about is loss of sensation.
Yeah.
People didn't completely understand what that was going to feel like, but that can be really difficult. And I think as well for relationships, sex and intimacy, that having that loss of sensation is really impactful. So it's just, I think, being really open, honest and upfront, allowing people to be fully informed when they're making decisions is so important, so that afterwards in their recovery, I think it certainly does help with adjusting. And another thing that we get asked a lot about is photographs, or can I see somebody? Because you can talk through what it's going to be like, and people can, on the internet now, there's so many pictures.
Yeah.
And we will often say it's really important to speak to your surgeon to see their work, because you can see good, bad, medium results by Googling, but it's really important to see your own surgeon's work.
Yeah, that's a really great point, actually. We tend to, sadly, show our better work.
Yeah.
And I think as the surgical fraternity, we need to be showing the range of work that we do. There's also an element that we want to avoid of what we call a bias, that you tend to offer what, as a surgeon, what it is that you, within your remit. And I think, individuals should have the access to everything. The delivery of that is also can be challenging. So that is obviously clearly the gold standard options available to everyone, but access in remote parts can be quite challenging at times. And as you said, it's time critical at times. So we want to get things rolling, but the pathway can be quite complex.
Yeah. I remember for me, everything happened so quickly. At first, I was having a lumpectomy, and then after my MRI, there was more tumour, so I needed a mastectomy. And all of a sudden, you're trying to make these decisions so quickly, and you're not really thinking rationally either because you're so emotional. It's very difficult, I think, within the time. And I do think it's so important to be given all your options. And to understand fully, because I also didn't know what I was going to wake up with. And I think that's quite worrying and scary as well. I didn't know if I was going to wake up with it closed, or I didn't know if I was going to have an expander in or an implant. And I think even going down to surgery, and I wanted the honesty, you don't know what you're going to wake up with or what it's going to look like. Is reconstruction available for everyone?
Back in 2021, Breast Cancer Now produced a report delivering real choice. It was after the COVID pandemic. It highlighted the problems that the NHS was facing in England with the backlogs to reconstruction, because immediate breast reconstruction was paused at the height of the pandemic, and that led to a backlog. But what it also showed was that there was areas in England that offer all options, and then there were other areas that weren't, because of how things are set up and capacity and theatre space and staff, that they couldn't offer all options. So what it did highlight is that some people may not be offered all options. And we've worked very closely with the Association of Breast Surgeons to try and, one, reduce the backlog. And some of the ways we've done that is looking at theatre capacity, theatre space, tariffs, which is the cost of these operations, because often the cost is not equivalent to the real cost. So the surgeons are doing these at almost a loss, really. And also a training fellowship where we can train surgeons to do more sort of microsurgery, so autologous options, but also allowing people to know that although it might not be available in their local area, if they are able to travel, they could opt to be referred to another hospital, which may not be close by, if they want to have autologous, their own tissue reconstruction, if it's not available in their own area.
Well, I was certainly happy with my reconstruction. I couldn't look at it for like over a week. I wanted, I think, the bruising and the swelling to settle down. But I'm really glad I went for it, and I'm very, very happy.
And I suppose one of the other things, just to add on that decision-making processes at Breast Cancer Now, we've also got a peer support service called Someone Like Me, which, again, when I was in practice, I often used to refer my patients to when they were given options. So everyone's experience of breast reconstruction is their own individual experience, but being able to speak to somebody, they're trained volunteers who they can speak to on the telephone. So I often used to say, ask to be matched with a volunteer who has had an implant-based reconstruction, ask to speak to a volunteer who maybe has had their own tissue reconstruction, and just speaking and listening to their experience of it and sort of getting to know what they went through, the recovery, how they prepared for that, can sometimes help with that decision making as well. And we can usually at Breast Cancer Now get those matches sort of within a couple of days. So again, that's sort of time critical when you're sort of making those decisions. They're able to speak to somebody. Or again, we've got nurses on our helpline that have been in practice or who are still in practice that can talk through what it was like when they supported their patients.
That is a brilliant support that you offer. And please, for anybody listening, if you do want any more information, please head over to breastcancernow.org. But no, that is so useful and helpful. Thank you so much for joining us today and chatting, and for all the work that you do for Breast Cancer Now. Thank you very, very much.
Thank you for having me.
And a massive thanks to Miss Georgette Oni for taking the time out to talk to us as well.
Stay informed, stay healthy. Thank you for listening.